So I appreciate that this is, for some people who haven't done pediatrics, this may be a bit like what the hell is going on sort of vibes, but it is something we need to learn how to do in pediatrics, because children don't present in the ways adults do sometimes. Sometimes they can have no symptoms apart from the fact that they aren't behaving as they normally would do. So it's very important to know what is normal for a child at their certain age, and also how we can apply that to medicine and different treatments. Okay, so the way I obviously like doing things is not just, it's going to be a bit of like information which you can read up yourself, and then we're going to do some cases, but it's only 19 slides, and I doubt it will last an hour. But also bear with me because I spilt water on my computer, so I'm using my iPad, so I have to go in between the messages and my main screen, and it's not that easy. So if there's any questions, Anush will tell me, and I think that'll be the best. Yeah, so Anush, if you just let me know any questions that come up, and we'll do it that way. Okay, so here we go. So I'm not sure you've all done this before, but this is how to take a pediatric history. So it's kind of very similar to what we normally do, but we add in a few things. So you find out the age, really important. You need the age in months and years, sort of really estimate where this child should be. You then see what they presented with. So that could be that they presented with that they had were passing very wet stool. They might be floppy. They may have been bleeding from somewhere. They could have had a fall. They could be snoring. They could be making weird sounds. They may look a bit blue. You need to find out what's going on. You need to find out how long it's been going on for, the normal stuff. And then a few little things. So we need to know about wet and dry nappies. The reason for that being if they could be dehydrated. Instead of asking, oh, do you feel a bit woozy? They're not going to tell you that. The parents will be able to tell you if their poos or wees, they've been weeing less, or their poos have been a bit more wet or dry than normally is being. Can ask how they're feeding. Are they bottle fed? Are they still being breastfed? If they're older, that may be a bit weird. But it's a really good way of estimating how this child is relative to their baseline. We then also need to know if they're being normal for themselves. Are they crying? Are they happy? Or are they very quiet and hugging? It's kind of difficult to tell little things, but you can get a good idea if this is a sick child or a very sick child or an okay child. And then we have bird. I wonder if this will work. Will this work? Oh, it won't work. It was a funny.
What are you trying to do?
Thing. There's a little thing.
Audio clip
which you can play. Yeah, but it doesn't matter. It doesn't matter. I think we're going to push ourselves here. So, okay, sorry, come back to it. So with a birth history, you kind of want to know about what happened antenatally. So antenatally is anything antenatal and perinatal and postnatal. So antenatal is before labour, perinatal is during labour, and postnatal is post-labour, post-delivery. So antenatal is like what's happened during the pregnancy. So did the mum take any medications? Did she have anything to take medication for? Did she have diabetes? Did she have preeclampsia? And did she have torches? Does anyone know what torches is? Obviously you know what a torch is, but does anyone know what torches means in terms of antenatal mum stuff? So I appreciate this is pediatrics, not obs and gynae. Yes, very good, thank you. So yes, these are in the infections can be transmitted to the baby. So there's things like toxoplasmosis, hepatitis, CMV, or the rubella, all these things that we don't want the mum to get, so they're screened for. They're only screened though for syphilis, HIV, and Hep B now. Those are only 3 that are screened normally. But if they have any signs of the other ones, they can also screen for those. But we want to know if the mum had any, because the reason we want to know if mum had those infections, they can pass to the baby. So you can get neonatal syphilis, you can get toxoplasmosis, and babies can get hepatitis from birth if the mum had it, because obviously it's a blood-borne infection. So we need to know about that. We need to know if the mum smoked at all, if they had any drug history. We need to know if they had any scans, so amniocentesis and chronic villus sampling, basically Down syndrome, if they have investigated for Down syndrome or any other inherited conditions, not inherited, but anything that could be genetic. And then perinatal. So what happened during labor? Did the baby have any neonatal sepsis or risk factors for neonatal sepsis? So risk factors for neonatal sepsis is basically if they're predate, if they're born pre their like normal time, so if they're premature babies, if the mum had a fever, if they were born floppy, if they had a fever when they were born, was the mum given any antibiotics during labor? Did the baby need any antibiotics? Did the baby need any oxygen therapy when they were born? All these things are things that we need to consider, and if that is the case, then the baby could have been septic depending on how old they are. How were they born? Were they born vaginally or were they born via C-section? This then will also put the baby at risk of different conditions depending on the way they've been born. Were they born prematurely? ABGAR, does anyone know what ABGAR is? Or ABGAR scoring for a baby? Oh, I can't see the chat.
I can see it. I can read it out if anyone says anything, don't worry.
Okay. So
you do by the way, ABGAR score is something that you do need to know. Yeah, that's exactly what it is. Yeah.
What did they say?
Appearance, pulse, grimace, and respiration.
Cool. So the ABGAR score is basically I would describe it as the A to E of babies after they're born. It's basically a way of seeing if they look floppy, if they're grimacing, and have reflexes. And I've seen them do it as soon as they're born. So the baby, if they're not crying for a while, they press this button above like this unit they have, and it sort of starts a clock. And by doing that, you measure all these things and it gives you a score. And that sort of tells you how well the baby is and how quickly they return to normal, or if they don't return to normal. And depending on that score, some babies will need to have other treatments. They may need to be cooled, and we can go over that later. But basically, just that's something you need to bear in mind. And it's really important because you need to know if this baby is someone who needs extra treatment after being born. Okay, so postnatally, did they have to stay on a while before they went home? Were they jaundiced? Did they have any sepsis? And did they have difficulty breathing, any feeding difficulties? Then this BIRD acronym, which is Immunizations, Red Book, and Developmental Milestones, which we're going to go into. Any past medical history they already have. Family history, learning about any consanguinity, if their mum and dad are related to each other, in a history of atopy, and the siblings, how are they doing, and then the social history. So it is a lot. And no one expects you to do all this in a normal history. This is a lot of stuff to do, but it does really, if you can nail this, it does give you a really good picture of what's happening and if there's anything you should be worried about. Okay.
I think this is quite likely to be a 10-minute station if it comes up in an OSCE last time.
Well, you think it is likely?
Yeah, I like if it comes up, it'll be 10 minutes or it'll be part of it.
You'll get a lot of time. And there's a lot you can go into here as well, like the whole birth history. That can be a whole station on itself. So I think just having a general idea of the sort of questions you'd like to ask is good. And break it down into that antenatal, perinatal, postnatal, and then the things just flow off for the questions you'd like to ask the mum or the dad. Yeah. Okay. So development is really important, and we're going to talk about it. So I'm going to kind of gloss over this a bit because we're going to go over this a few times anyway, but development is broken down into 4 domains: gross motor, fine motor, which includes vision, speech and language, which includes hearing, and social, emotion, and behavior. So gross motor is the movement. It's just moving their arms and legs, not just general movement. Fine motor is like pincer grip, clenching their fists and holding things, and it also includes vision. Speech and language is self-explanatory. And social emotional behavior is how do they behave with children? Do they interact with adults? Do they get emotionally upset? These sort of things, which obviously develop depending on the age they are, but sometimes some children can have low levels of development, especially in that domain, which we will talk about later. So every year there's PassMed and UCL go into great detail about the different ages you should learn things. And I would say that it isn't worth your time learning it. It is worth your time learning. Oh, someone raised their hand. Did someone ask a question? Oh, sorry, maybe not.
Just changed their mind.
Oh, sorry. If you have any questions, please just speak up or put in the chat. I'm happy to be interrupted at any time. So Learning your normal ages of achievement, yes. More importantly, learn your red flags. And I'm going to talk about a couple of them in a second. So the ones they go on about is like hand dominance. So when does the child get hand dominance, which we'll talk about. And also when they can start walking is really important. And when they can sit up and hold their head up, which we're going to talk about. These are the red flags which sometimes they ask about. Another one is when babies learn to smile is also a good one. But I would say it comes with practice, and I wouldn't learn a list. I would apply it to situations which we're going to do, and we'll talk about that. So also really quickly, there's a difference between global development delay and delay in one domain. So delay in one domain literally just means delay in one domain. Global development delay just means one, two or more. So it doesn't have to be all four for the global development delay. It just has to be two or more. And that's a question we had in SBA last year, actually. Like, how would you? I think the question was describing a child, and it was how would you? What we say about this child's development? Yeah. And it was like delay in motor, delay in a global development delay, or no delay. It was that sort of question. So they do come up, and it's just understanding what is normal. And the questions tend to be really obvious that this isn't normal. So I wouldn't be too concerned about that. I would be more going to red flags. Red flags are important. Not knowing when does a baby put 3 bricks on top of each other. That is a waste of your time and will never help you clinically, unless you go into this speciality probably.
I don't think UCL like focusing on that anyway. I think they like.
They don't. You're right. I'm just putting it out there that this was something that if I didn't even look at, I think I still would have been fine in a way, because it's you can kind of work it out. But let's carry on. So we talked a bit about risk factors and the perinatal, postnatal, and antenatal, and also hereditary. We talked a bit about family history. So things you can ask about autosomal illnesses. It's an awkward question, but we do need to ask. Any unexplained childhood illnesses or death. And then any other difficulties, be that hearing or muscular or learning or neuro. Then we ask about their birth, and this is when we go into like what we talked about already. Did they have any hypoxic ischemic encephalopathy, which we're going to talk about, HIE? Decreased fetal movements from birth. Any postnatal infections? Did they stay a long time in the hospital? And did they have any seizures? So let's carry on. So let's go in more detail. So gross motor. I'm not going to spend too long with this because I think you can guys look over yourself. But this is how we sort of break it down. So you start with your head. The baby sort of is quite not floppy when they're born, but they can't really support their own head because it weighs a ton and they have very little bodies. So what normal is that they can sort of do what this lovely guy is doing on the side, and they raise their head like this on their tummy from 6 weeks. But a red flag, as what I was talking about, is when at 6 months, they're still not able to do this. So you can see how much difference it is between 6 weeks and 6 months. So if they have a floppy head, not able to raise it by 6 months, this could be pointing to a muscular disease or neurological disease, which means that they're unable to raise their head. So that gives you an idea. Then standing. Normally, 6 months, a red flag is if you're not able to weight bear from 1 year. Now, walking, really important one to learn. I think that's the only one I would learn, really, is that normally kids can walk from 1 year, but some kids are bum shufflers, and bum shufflers are the opposite. So they literally shuffle on their bum, and that means they can actually take a bit longer to walk. So you literally ask the question, were they bum shufflers? And if they are, there's a bit of leeway. But most kids should be walking by 1 year. A red flag is if they're not walking by 18 months and need to be investigated. What do you think is the most common reason why kids don't walk by 18 months? We're going to go into this, but just on top of your heads, what do you think is the most common reason why kids aren't walking by 18 months? I think there are a few answers to this, but basically, guess what I'm thinking.
Read my mind.
Read my mind. Well, not so much in my mind. You can't.
No, there is an answer. So cerebral palsy is a cause, but I don't think it's the most common cause. I don't think it's the one Jake was going for.
It wouldn't be something that would present as not being able to walk from 18 months. You'd probably have some deficit from birth.
But yeah, like it's definitely a cause.
Definitely would be a reason why they won't be walking at 18 months. So,
Oh.
you should basically you've all heard of it. It's Duchenne's muscular dystrophy, and the reason that the UCL do like it, I wouldn't say it's the most common actually, but it's definitely the one that is like a very top of your list reason why kids aren't walking. And they tend to have these legs, and I've now forgotten it, but they have really strong calves. But their legs go. What's that called, Anush? So they got very strong calves, but their upper legs are quite weaker.
I can't remember.
I can't remember. Anyway, it's a very common cause for not. And it's a red flag. Running, not so much important, but 18 months is normal. Not running at 2 years is a red flag. So things to also look for. Sorry.
I would also say that DMD is common in exams, but not in real life. It's around 200 per million in real life.
Yeah, but it is.
Yeah.
It's something to remember that it's very common thing they like to talk about. That's the reason that they can't walk.
DDH is a very good shout, Naomi, but you would probably get it on screening. We'll talk about DDH another day because it's super important, actually. I don't. The commonest cause that you should know of if someone asks is constitutional delay. Does anyone know what that means? Does anyone know what constitutional delay means? Not quite. Poor growth. Good idea, but not quite. So, as in, it could be to do with poor growth. Constitutional delay basically means, it's like slow growth, but not really pathological. So you'd ask, did like one of the parents, like, were they slow to walk? So malnourishment is a pathological cause of slow growth, but just like in growth, you can have like slow growth due to a pathological cause. You can also have it because one of the parents was a bit slow at growing. Similarly, one of the parents might have been a bit slow at walking. So, like, it's important to take the parents into consideration as well, because it might actually be normal variant. Yeah.
Exactly. Yeah.
Constitutional delay does usually refer to growth, though. Yeah, you're right. My bad.
So another important thing before I forget it as well is sometimes that kids you need to know, but sometimes when they develop a skill, if they lose that skill, that is also really important to pick up, and that can be something you need to look into quickly, because if they've developed to be able to walk and they no longer can walk, you need to find out why. So it's really good to know how the development's been throughout their life, not just where they are now. Okay. So fine motor is what we're talking about. So you have different grips. So first of all, when they're born, they should have gaze fixation. So basically that means that when you make noises or you interact with them, they're looking at you. You know, babies have that big wide-eyed look about them, like they've just been startled. That's like them gazing at you whilst you're talking. That's normal from 6 weeks. If they're not doing that at 3 months, it's a red flag. Now, different grips. So palmar grasp or primitive grip is like that. So you see it like this. It's like, I can't really do it. It's like that. It's just them holding things in their hand. Pincer grip is like this, the pincer. And they haven't developed the palmar grasp from 6 months, that's a red flag. If they haven't developed the pincer grip from 1 year, that's a red flag. So you just remember that there's 2 types of grip. Pincer, obviously, is a bit more developed, so that's the second one. Drawing, forget about it. I just include it because you have to, but I actually can't bother to explain it. It's just silly. It's never going to be important. And then if they have any hand preference before 3 years, then that is really important. And someone mentioned cerebral palsy, and that is one of the commonest things to see. In that is that because they've had an infarct or stroke, or not stroke, but an ischemic attack to one side of their brain, then the other side, because you get hemiplegia, then that side, if you remember your stroke, then you can have hand preference before 3 years. And normally they say 1 year. So that is a big red flag to look out for. So if they have hand preference, so they use their left hand more than their right before 3 years, if the mum comes and said, oh, he's left-handed and he's 6 months old, that should be raise a red flag, and you want to know why. Does that make sense? If you think about it, it's just that, imagine if they had a stroke, if anyone was done, remember their neuro from last year, they have a stroke, then you get hemiplegia. So the opposite sides. It's literally the same thing, but we're going to talk about that just at the end, and someone already mentioned it. Okay. So, anyone got any questions? Any questions at all? Okay. Feel free to just say them whenever. So, language. We break this down into expressive and verbal. First of all, they should localize to noise, and we're going to talk about that in a sec, like loud sounds and looking around. And then also their expressive and non-verbal language, so they're reaching, pulling, pointing. Basically, if they're not responding to voice or sound, that should be red flag from 6 weeks, so it's a bit earlier. Verbal can be broken down to syllables, words, sentences, and question stories. I think the first two are important from my own learning, in that babbling, so no sounds, by 12 months, or 18 months for no words. That's the two I remembered. But the 3 words from 4 years and 3 years, forget it. The babbling and the no words is important, and understanding how babies can talk. So if a baby you see a child, and they are 18 months, they're 12 months old, and then they're 3 years old, and they're not talking that much, and they're not speaking as much, and they're not interacting like you think a 3-year-old should do. What are you worried about in that sort of child who isn't languagely developed? That's not the word. Whose language isn't as developed as it should be by 3 years, or even 8. What should you be concerned about? Exactly. Hearing. Very good. So, and we're going to talk a bit more about that in a case I've got, but you can't. You do have some innate language, but you learn language by hearing. And if kids don't hear for certain reasons, which we'll talk about, then they won't develop their language skills properly. And that could be why there's delay in that singular domain. So it's very important to know about their baseline. When do they first start speaking? When do they first start interacting and communicating with you? So that's important to do. Okay. Will it let me... Oh, can it let me go to the next? I don't think it will let me go. But I think, oh, here we go. No, I just need to, there we go. So, social behavior, last one, eye contact. If they have no eye contact, that's a red flag. 8 weeks for smile, remember that. Normally by 6 weeks, if they're not doing it by 8 weeks, that's a red flag. Imaginative play, like feeding a doll, and also showing interest, red flag by 2 years. They talk about like playing with other children. That's something you need to be aware of. And so if all these things, language, social behavior, what are you looking into there? If any child has a delay in those domains, specifically social and behavior, what sort of things would you be interested in, or not interested, but you'd be thinking about? I'll have to literally go. I see a little bit up. Yeah. Good.
ASDs.
So, yeah. So it's a topic, I think, for another time, because it's quite a big topic, and it's one that we should go over. But definitely, so these children are their engagement with their parents and their siblings and their other children their age is reduced. Their language ability is less, and as you say, it's a spectrum. So some children can have small amounts in this, and there's a whole criteria which I think you go into a lot of learning about in your like psychotherapy part, or not psychotherapy, your psychology part to your pediatrics placement. Not psychology, but yeah, that sort of thing. We got a lot of teaching that last year, which is very good. So yeah, and we'll talk another time, but exactly, autism spectrum disorder. Those are sort of things that if you have a reduction in those 2 domains specifically, you'd be concerned about. Okay, and general red flags. As I said, regression. If you lose any developmental milestones, you go back, that is a red flag. So go back 1 step. If they were walking, now they're not walking. If they were talking, now they're not talking. And if there's any abnormal movements, fits, seizures, and jerks, this can be very subtle. That is a red flag. And if there's any asymmetry, and I'm not sure why I put less than 3 there, can't remember, but might be a heart, I don't know. But if there's any asymmetry to their, like one arm is more developed than another, or they're using their arm more than one, or their left leg is more powerful than their right, that's a red flag, obviously. Okay, so now this is a case, and I think in terms of time and to everyone's intention, we're just going to basically put it up and we'll talk about it. So this is the first history. So this is Jacob. He's a 7-month-old male baby, and unfortunately Jacob won't talk. And oh, don't we all wish this was the case? Jacob doesn't respond to his name or to his siblings. And when you examine Jacob, you realize he doesn't startle. And you do your history and you find out that mum was born abroad when they were in Morocco and he had a normal delivery, has had all his immunizations so far at 7 months old. Talk to me, people. What's wrong with me? What's wrong with my namesake? What do you think is going on here? And then bonus points. Why have I put in that I was born? I was not. Sorry. Why Jacob was born in Morocco? Why is that important? Really niche. Well, not even niche. I don't think it's actually that important. Cool. Nice. So we definitely want to consider hearing problems. Very good, Claudia. Ooh, someone says something. Ah, Naomi. 4 marks. Very, very good. Very, very good. Yes. Very good as well. Excellent. You always got to know about their language, but I think what they'll normally be able to probably hear what their mum or dad are saying, so that's true. Very good. And also maternal infections. Yes, we want to rule out anything that's infecting their ears, things like CMV. Definitely, we want to know about any neurological disorders that they have. But 4 marks to anyone who thought about the newborn hearing test. Excellent. So, hearing issues. Very good, guys. You're all experts. So, there's the newborn hearing scheme, which is the Guthrie. If Jacob was born in Morocco, there's a possibility that he didn't have it at the time. However, the Guthrie test doesn't rule out the possibility of hearing issues. Okay. So we can go over newborn screening another time, but the Guthrie test is definitely one that you not knowing you about. It's something you interest, but they test their hearing when they're born. And the questions you ask are: does the baby start with loud sounds, door slamming, sirens? And when the baby, I always thought it was funny. It sounds like a dog. So does the baby hear the key telling when mum and dad arrive? Basically, does the baby localize? Do they hear and do they put sounds to images? Do they understand what's going on? Things you want to do, obviously you want to see audiology. Salt assessment. Do I want them to check if their salt level's okay, or what do I want to do there? What is a salt assessment? Oh, someone said it. Oh,
Yeah,
yes. So
speech.
Yeah, sorry. So speech and language therapy. Very good. They also do this on the stroke ward. So all the stroke patients that I've been seeing this week, they all get SALT review all the time to check their speech and their language to see how that is different from baseline. So we want to make sure that this kid may possibly, if he has any hearing difficulties, is his language affected as well? Could this child also have language delay, and how can we help him? MDT obviously is here. We're going to need involvement with the pediatric team from the audiology team. They may require a complex plan and helpfully help their needs and outline any additional help they require. Is everyone happy with this? I think this is quite obvious in terms of the presenting history, but this sort of thing we need to look out for. This is, I'll go back to it. This is a 7-month-old baby. They're not making any sounds. And if I go back quickly to, oh, please let me go back. Please let me go back. Okay. So by even though like at 12 months it's normal for it to not make any sounds, they probably should be responding to voice by 6 weeks. Okay. So so he doesn't respond to his name or to his sibling. So basically that means that he's not responding as they were speaking to. So he should be focusing in on sounds by at least 6 weeks. Okay. So at 7 months, that is a clear red flag. Good job, everyone. Fantastic. So this is Isabella. She is a 3.5-year-old female child, and the care worker knows that Isabella appears unkempt and withdrawn. Drug and substance abuse in the household on your study history, and there's no concerns. Okay, this one's a bit trickier and a bit more off the beaten path. What are we? We're not what do we think is going on? What is everyone thinking about? Like, is Isabella? What could be going on with Isabella?
also it's worth pointing out that now the we spoke about language barriers and like what languages they're speaking. This is super relevant now. It wasn't as relevant in the last one, but now it's super relevant.
So someone said neglect and safeguarding issues. Good. So this, if any child, if you're worried about safeguarding, there's always in every pediatric department, there's a safeguarding health worker who you always speak to. And in some instances, you can always involve the police. So with any child, there's other things to look out for. So, and again, I don't want to go into another, we can go in another tangent here, all about child abuse. But with this presentation, if they appear unkept and withdrawn, if they're not interacting with adults as you expect a normal 3.5-year-old child to do, or on the otherwise, if they are very keen to interact with you, they will hug you the entire time. And if they have no, if they are behaving inappropriately for a 3.5-year-old child should be behaving, like making crude jokes or sexual references. Again, this is more about sexual abuse. Then these are things that to be aware of. With this child, Isabella, the fact that obviously the clue could be there's known drug abuse at home, but her actual appearance and the fact that she has development possibly. So what domain in development does this child have? Okay, so this child has speech and language in their speech and language development, but also could be their social and emotional development. Okay, so there you go. So with neglect deprivation, with severe psychosis, even severe neglect can cause a child to develop language development delay. So the two things that are most common in causing language delay is in their hearing difficulties or also neglect. Because if you're not interacting with this child, if you're not talking to this child, if you're not giving this child love, attention, care, devotion, they will not learn how to speak and how to interact and how to present themselves to people and how to interact. So it's really important that children are looked after properly. And when this doesn't happen, they can be really seriously affected. So we may need to have social care input here. We need speech and language therapy, a pediatric assessment. Again, we need to make a big plan to make sure that we have the child's special needs and any additional help they have. And we need to possibly this child, if we consider them to be unsafe at home, maybe social care will need input and decide what's best for the child. Okay, only a couple more, so not long. I didn't want to keep it too long. So this is Mike. He's 6 years old, so a bit older now. So the teacher notices Mike has struggling with reading and writing assessments. He's a normal IQ and has normal development in other areas, but he struggles to find the words he wants to use and particularly struggles with verbs. Okay, what's going on here then? Six years old this time, so a little older. So was anyone good development language day? Yeah, thank you, Divya. So this is a bit more complicated. Exactly, development language disorder. This is very good. This is basically a condition which is idiopathic. There's not really any cause to it, but it's something where a child has difficulty understanding or using spoken language. So rather than this being some external output such as neglect, or if there was an actual problem with them being able to hear in their auditory system, this is simply that they're slow to develop their language skills. For a 6-year-old, you probably expect them to be expressing and speaking normally or quite adequate at this point. And if they're not, then this could be the reason. And it's got a diagnosis exclusion, so you want to also rule out anything else. They can have a significant impact on progress at school and likely to catch up without help. You also always want have an audiology referral as well to rule out hearing issues, and you want a SALT assessment. And then you have your EHC plan. Would someone say something else? Good job. You're very good. Dyslexia. So it kind of encompasses this. So you would say that anyone who struggles to probably read as quickly as they shouldn't probably be normally having to spend a lot of time reading, that could be dyslexia. But with this developmental language disorder, it kind of encompasses that, and it's idiopathic, so there's no real cause for it. I'm going to be honest, I'm not an expert in it and on this sort of topic, but I think it's sort of, you're right, there are parts of this which sort of encompass dyslexia, and this is how I describe dyslexia, but this is sort of developmental language disorder, which just means that they're taking longer to develop their language skills than they would normally do. Okay, so this is the final one. So 7-year-old female, her primary school teacher noticed that the child runs a bit oddly. She cradles her left hand as she runs, like this. So she holds her hand like this as she runs. So mum states that she had a low AGPAR score at birth and was called as a precaution. She has no developmental concerns. All immunizations are up to date, and on asking the mother, there's no consanguinity. There's no family history. Okay, so I've got a few questions, everyone. The presenting complaint. What do we think about a child that runs a bit oddly and cradles her left hand as she runs? What could that be? Any
Cerebral
guesses?
palsy.
Second time lucky. You win,
Yeah.
Joshua. Very good. Yes. So this is you remember from last year about stroke, you get your flexors and extensors. So you sometimes on your upper arm, your upper limb, your flexors can be stronger than your extensors, and on your lower limb, your extensors are stronger than your flexors. So you get this sort of like this position here. Oh, look, I'm sure my bicep is a bit weird. But you get like, you cradle your arm like this, and you run a bit weirdly because you've got slight hemiplegia down one side. Or oddly, I shouldn't say weirdly, oddly, not as you normally should do. The low AGPAR score, we talked about this. So they were probably not grimacing, their reflexes weren't great, their tone wasn't as it should be. And because of that, there was a chance we thought that this baby could be having hypoxic ischemic encephalopathy, and they normally cooled. So that means that they're basically placed in this, not a chamber, but this sort of unit which cools them, and that helps reduce the need of the brain, the blood supply of the brain, and tries to prevent any damage. So with cerebral palsy, I haven't added a lot of notes in because I'm not going to lie, I was struggling for time here. But sometimes they can only, cerebral palsy isn't your classic like disabled child who is wheelchair bound and is speaking oddly. They can actually be quite mild in their form, and they can present later because as you develop, the way your brain changes, not changes, but it grows in its connection. Sometimes when there's damage to it earlier, it may not be able to do it as well as other children can. So when they run or when they can use, that's the child where you see them using their left or their right hand earlier than 3 years. That's the sort of thing we talk about, and that's why it's a red flag. Cerebral palsy can be broken down depending on the extent of the insult to the brain. So hemiplegia, paraplegia, quadriplegia, and it's a very serious condition. These children need a lot of special care, and in the most severe form. And we worry especially about their swallowing, because if you remember, the lower your GCS, the less safe you'll swallow. So these children need to be really looked after and cared for, and it's can be a cause of global developmental delay. So lots of information. Definitely want to go over and sort of learn those red flags. Also, I found helpful was practicing with friends who did this sort of thing where they had red flags you could ask about. So they pretend to be the parent of the child, and then you just go through like, so when did they first learn to run? When did they first speak? What was their first word? Did they have any siblings? How does their development compare to their siblings? These are all very good OSCE sort of things to have. but again, I wouldn't go into information overload about learning every single stage, like each brick that they put on top of each other when they were playing in school. Like, it's just not helpful. And it is helpful, but it's just not worth your time. So that was quite a short one. It was only 40 minutes. But does anyone have any questions? Ask away. But I hope you found that useful. Next time.
Yeah, I think just to emphasize what Jake did, like, I think you can prioritize which milestones are important. Like, I think there are some very important ones, and you'll realize this over the course of the year, or rather the course of pediatrics.
Yeah.
So don't, like, I mean, by all means, if you want to remember all of them, and you go for it. Like, but if you feel like you can't remember all of them and you want to prioritize some, that's fine as well.
I would also say take-home messages, which I should on the slide on. I apologize. Take-home messages for me would be understanding the ABCAR score and how that is used in pediatrics, especially with when the baby is born, and what the score would indicate, especially with cooling and HIE, and also understanding how screening tests for children, like we went to talk about the Guthrie today, but there's a couple of others, like looking at thyroid and other things. Those are important, and understanding what constitutes global development delay and only one field of delay. Okay, so thanks, guys. Anyone any questions? Let me know. But yeah, good job.
Feedback. Wait 1 second.
Next time I'm going to do some cardio, and I'll break it down into acyanotic and cyanotic. So I think it will be useful. So I'll probably be in a couple of weeks. But I hope everyone's keeping safe. Try and enjoy yourself, because it's a long year, and it's going to be a very long year, especially with lockdown at the moment. But yeah, pace yourself, and you'll all be absolutely fine with whatever. Lights. Ciao, everybody. Another time. Yeah, unless anyone's got any questions, but well done. See you later, Noosh.